Hi friends, um, this is Dr. T and this is clinical medicine with Dr. T. So guys, I want us to talk about a clinical approach to a patient with jaundice. I know that many people are used um, to an approach to jaundice. This is different. It's gonna be a clinical approach, meaning when a patient that has got jaundice pitches up where you are and you have to attend to the patient, what would be your thinking around that patient? What would be your thinking in terms of history? What would be your thinking in terms of examination? What would be your thinking in terms of the investigations that you're going to do and all of that? And this is, remember, this is not biochemistry, it's clinical medicine. So we're not going to go and talk about the breakdown of red cells. Maybe I might do that in the future, but it's not really very important for clinical medicine. Yeah, so as we all know that jaundice is the yellowing of the conjunctiva, yellowing of the mucosa, yellowing of the skin as well, meaning so yellowing of the mucosa, the soft palate, and all of that. And this is an approach to an adult with jaundice, so it's different from neonates. So guys, when we have a patient with jaundice, there's like four conditions that we need to make sure that the patient does not have, because those four conditions are the ones that are likely to kill a patient with jaundice. Jaundice on its own does not really kill, but the underlying cause, if it's one of those four, the patient is in trouble. That patient is critical. And these are the four things that we need to make sure that the patient doesn't have. The first one is acute liver failure. Number two, acute cholangitis. Number three, massive hemolysis. Number four, malaria. These are the four conditions that when a patient with jaundice, we must make sure that that patient doesn't have any of those, because those are the four things that are likely to kill the patient. Okay, so just have those in mind. We are going to talk about them later on. So our approach will start from history. So in terms of the history, okay, the patient is going to come in with saying, okay, I've got yellow eyes. Or, it's even interesting that, there are patients that would come in and then they will tell you that I've come because my sister or my brother or any family member told me that I've got yellow eyes, and that they were not aware of it, or they were not sick. They didn't have any other symptoms, just the yellow eyes. So how um, that's how innocent jaundice can be. And then there are extremes as well. I don't know if I'm using the right terminology. I don't want to say not significant. So, and then those would be like the extreme. Someone who's got jaundice but they've got no symptoms, and then someone who's in acute liver failure or who's got cholangitis. Those are like two extreme ends. So I'm trying to say is that you can get a patient who's got jaundice, who's walking, talking, active, doing everything, but just they've got yellow eyes, or someone else told them that, yeah, your eyes, they look yellow. So obviously they will come in with yellow eyes, which we call it jaundice. And then Yes, they will tell us about the symptoms that they're also having and all of that and all of that. Like I've said in my tutorial, history taking tutorial, that the patient will tell you how they are feeling, their symptoms, but a good history taking is not about how vocal the patient is. It's not about how much information the patient has given you. It's about the doctor. Are you able to ask relevant questions? Are you able to ask questions that will help you with the diagnosis? And that can only come when you read. It depends on how much you know as a doctor, how much you know about that clinical presentation, how much you know. And there are people who know PV bleeding like in and out. They can just come with diagnosis just like that. But if you're not familiar with PV bleeding, so a patient with PV bleeding, it's like someone saying an unconscious patient, approach to an unconscious patient. It depends how much do you know about the causes of unconsciousness and what is important in the history, what is important in the stabilization, what is important, all those things. So it's all about how much do you know. So, and I always say that as junior doctors, our only backup is reading. We don't have experience. So, because another thing is, when a patient is giving you symptoms, for them they'll just give you symptoms. But now it's up to you to take that information and make sense of it. And there's nothing wrong when a patient is telling you, let's say they say I've got yellow eyes, and then I also have waist ache, I also have ear ache. You see, they are moving away from the presenting illness now. So it's your right as a doctor to take the patient back and say, okay, you mentioned that you've got yellow eyes. If they don't give you the information that you expect, you must specifically ask for it. Like for instance, when you've got jaundice, I want to know if you've got features of obstruction or cholestasis. Of cholestasis. So if they don't give me features of cholestasis, I will specifically ask them, are you having itching of the skin? Are you having coke-colored urine? Are you having pale stools? Are you having fatty stools? So so a patient who's got jaundice and then they've got cholestasis symptoms, they are likely to be having obstructive jaundice. So my investigations, as much as I'm gonna do the blood and everything, but um I'm thinking about causes of post-hepatic jaundice, also called surgical jaundice already when they've got that. So that's one. Number two, if they don't give me this, I'm gonna ask them about because I'm thinking about viral hepatitis as well. Meaning, I'm gonna ask them about systemic symptoms like fever, headache, malaise, lethargy, like feeling weak, body pains. They might even have flu-like symptoms. And then also, I'm also thinking about hemolytic causes. When you've got hemolysis, the patient might have anemia and they might have symptomatic anemia like dizziness, headache, feeling weak, They might also present with the complications of anemia, like they might have shortness of breath, they might have swelling of their legs, they might have tachycardia. Yeah, one of the symptoms of would be tachycardia. One of the symptoms of anemia. They also have swelling of the legs. Why would a patient with anemia have swelling of the legs? There's something called high output cardiac failure. Anemia causes high output cardiac failure. Go and read about it. So this is my thinking. Someone who's got jaundice. This is my thinking. So if they deny any of these, I'm gonna go into detail and ask about this as well. And also drugs and toxins become very important here. Recent drug used, drugs not in the sense that chronic medication, no, just recent drug use that the patient has taken recently. And also herbal medications. Never forget herbal medications here. Herbal meds and all of that. So you want to ask about that, what was recently ingested and all of that. And another thing that is important is you want to ask them about other symptoms like weight loss, and anorexia, because you're thinking about malignancy as well there. And obviously, guys, it's impossible to cover everything, but these are the things that you need to think about on a patient who's got jaundice. It's impossible to cover everything. So let's move on to past medical history. Okay, let's move on to past medical history. What is important in the past medical history? Obviously, hemolytic anemias. There are patients who will tell you that I was diagnosed with hemolytic anemia, then they tell you what type of hemolytic anemia was. And also malignancy, and also chronic liver disease. Maybe the patient is known with chronic liver disease. CCF, what else under past medical history? Under surgical history, past surgical history, you just want to ask them if they've done any operation, especially in the abdomen, like biliary tree operation, things like that. Things like that, and any other operation as well. There's something called post-operative cholestasis. So recent operation there. You just want to ask about that. I don't always ask about recent travel history, but travel history becomes very important when you're thinking about infectious disease. So you want to know where have they been in the past 2 weeks, in the past month, whatever the case might be, depending on when did the jaundice start. Because we are thinking about, there are areas that are very known to have hepatitis E, for instance, also malaria, recent travel to around the Kruger National Park, Mozambique, places like that. And that would be, so it becomes very important. Travel history is important and also when I think about DVT, all those things, PE, travel history becomes important. Immobility, because of you are immobile when you are traveling, you're just sitting there, and yeah. And then now you can do so also things like alcohol intake becomes very important. What is their pattern of alcohol consumption? Are they known to be using alcohol excessively? All those things. I can promise you one thing, guys. With this kind of an approach, if you leave things out, they'll be like small things. Okay, so let's say now we are done with our history. Now we want to get to our physical examination. So a patient who's got those will not come in and say, I've got acute liver failure, I've got acute cholangitis, I've got massive hemolysis, I've got malaria. You will need to make that call. So now let's say we are happy with our history. Now we do the observation and examination part. First of all, describe the patient. How are they? This, when I was a student, this thing of describing a patient, we're just doing it. But I've realized that is very, very important, especially when you've got a patient whom, when you see them and then 2 hours later or 3 hours later, they have died. And then they come back to check the file. How was the patient when the patient came? When you looked at the patient, how was the patient? And all of that. And I've learned one thing, that after describing the patient, how they look, the next thing that is very important is the vital signs. The BP, the pulse, the temperature, sets. Blood sugar becomes important in certain conditions. It's a vital sign in certain conditions. The RR. For instance, if you describe a patient and say they look toxic, they are ill-looking, they look cachexic, so already we know. So you have given us a good description. The issue of Jack-Hold and all those things, obviously the patient is going to have jaundice, because that's the presenting a problem. They will have jaundice. If they're hemolyzing, they will have anemia. But if you've got jaundice but you don't have anemia, maybe you've got a mild hemolysis or you don't have hemolysis at all. Clubbing, if they are having any chronic liver disease, they might have the clubbing. Cyanosis, can't think of cause of cyanosis now on a jaundiced patient. Edema, if they've got heart failure or if they've got also chronic liver disease, like portal hypertension. Lymph nodes, if they've got some kind of malignancy going on. Okay, so the blood sugar and also the GCS of this patient becomes very important as well. For you to have acute liver failure can present in, the patient might have hypoglycemia. They might have, they might be bleeding clinical, they might be having ecchymosis, they might just be having bruises, or they might complain that if I bump myself, I just bleed a lot, things like that. That would be clinical. But if you do bloods and check the INR and the PT, they will have derangement, a sign of coagulopathy. Remember, that's the synthetic function of the liver. So that will be someone who's got, as long as the INR is fine, as long as their PT is fine, and then they've got a normal blood sugar, they are unlikely to be having liver failure. And then someone who's got jaundice and then they've got a tachycardia, they've got a high temperature, they are likely to be having acute cholangitis, just based on vital signs. You've got jaundice with a tachycardia, with a fever, like a high temperature, they are likely to be having acute cholangitis. and you come to the BP, you see that, okay, the BP in this patient is low. They might be getting into septic shock because of the acute cholangitis. Okay, fine. Massive hemolysis. So this patient is gonna be very pale. Massive hemolysis is gonna be very pale, such that if you do their HB, the HB is gonna be very low. So that's a critical patient. Malaria patients will come in with fever, they'll be weak, they'll be sweating, all those things. But obviously, one way of diagnosing is to do a peripheral smear. So based on this, you can suspect those, even though you're gonna run test. But whatever that happens, none of these patients should go home. None of those patients should go home. Okay, so the system of interest here would be the abdominal examination first. So you want to see if they've got stigmata for chronic liver disease, spider nevi, ascites, hepatomegaly. Splenomegaly becomes also, to assess for splenomegaly becomes very important, especially if you've got hypersplenism, whereby you've got excessive hemolysis because of hypersplenism. So you want to check for that. Check for ascites. You want to check for spider nevi. You want to check for hepatomegaly, splenomegaly, and also PR. You can check for, you can confirm pale stools on a PR. You can also check for hemorrhoids. When you've got massive cirrhosis, you end up getting portal hypertension, and then you get those veins dilating in the anal, around the anal canal. And then you can check for, and then now you can examine other systems as well. Make sure that you check for lymph nodes. Make sure that you check for lymph nodes then. And do a head-to-toe examination. On the CVS, you want to check if they're developing any features of heart failure. They're having any mama or things like that. And then swelling of the legs, we examine them, MSS, all those things. Which is fine. Okay, guys, I don't want us to have a very long video. Let me upload this one and then I'll do part 2 now. Thanks for watching.